I'm not talking about secondary prevention now. There, everyone should start a statin, barring a contraindication. But I'm talking about primary prevention. Do you guys believe in a stepped approach, as is often recommended, but then the reality of, oh, they didn't actually come back for their 6-month appointment? Or do you just initiate statin right away in the high-risk primary prevention patients? So is it a concurrent approach or a stepped approach?
Yes, and I think it's going to depend male, female, because women who are childbearing age who may have a relatively high LDL, you may want to withhold statin therapy until they're through having their children and breastfeeding and so forth. But by and large, if their LDL is at least 190 based on the new guidelines, they're diabetic, it is a clear indication to start statins. And I do concomitantly will recommend lifestyle. And part of that lifestyle, dietary cholesterol is one thing, but there's that negative regulatory mechanism through cholesterol, through hepatic upregulation of LDL receptors and intracellular production. But saturated fat is a big culprit. So I try to recommend reducing animal-based saturated fat, but as Steve points out, on average you only get about a 10% reduction, but I will do that concomitantly and say, medication, you need to be on medicine, but you also need to monitor your lifestyle.
Well, you said diabetes and LDL greater than 190, but what about Steve's patient, 150 and a bunch of risk factors? There, do you go concurrent with diet or do you do it as stepped therapy?
So I think it's important, this is where we get into the whole concept of risk assessment. And it's the issue is that most people think the LDL for 190 is straightforward, 200 LDL, but what most people are confused with, they say, well, I got borderline blood pressure, and you look at their blood pressure, it's consistently 145, but it's borderline, and then their HDL is low with it, and they say, well, I don't have diabetes, but they have impaired fasting glucose.
And their waist and hip ratio.
Then they've got metabolic syndrome, and it turns out, well, my parents didn't, but my uncle had a heart attack, So it's the clustering of risk factors, a bunch of things that are abnormal, and so they say, well, nothing's really that bad, but it's multiplicative. So, if you get 4 of them, it's 2 to the 4th power as compared to having one thing that's high. So now I think the lifestyle part, one thing that's very important is that because I would start them on a statin. On those patients, when I see this, I say, we're going to start you on a statin. Now, it's very important in terms of your diet and exercise because it's important that you don't get diabetes. And we know from DPP that you can reduce onset of diabetes by 60% for that person with impaired fasting glucose, and that helps worry the concern. They say, well, doesn't the statin worsen the risk for diabetes? So, your lifestyle can make a huge impact, although it doesn't do much for cholesterol. It does a lot for diabetes. It does a lot for blood pressure. It's the same as a medication for blood pressure. It does a lot for your triglycerides. So the lifestyle argument to me is I'm going to help control those other risk factors. It'll help your cholesterol a little bit. Maybe you use a lower dose for it. But I would not. And then, if you lost 30 pounds and everything was incredible, yeah, we could consider stopping in the future, but let's start now and not waste time.
So let
Steve,
me be provocative for a moment.
Oh,
if I
you've
could.
already been provocative. This is going to generate so many comments on the webpage once this gets posted that you said that it doesn't have to be lifestyle first. But let me just challenge you. I agree with you. A lot of times the patient doesn't come back for the 6 months, lost a follow-up, and they come back with their event. We see that a lot. In particular in cardiology. But what about the flip side, though? Because you're telling this couch potato, multiple risk factors, start exercising, and here is your diet, and now a statin. And now, a week later, they haven't exercised, their thighs hurt. It's the statin's fault. I'm going to stop the statin. Isn't that a risk when you just do everything at once?
It is a risk, okay? So let me be even more provocative here,
Uh-oh.
okay? So somebody comes to see you, they're 50 years old. They don't have a lot of other risk factors except maybe family history. And their LDL is 150. And their HDL is 32. And, they're overweight, but they, for 100 people like that, you tell to lose weight and exercise and do that. I'd be interested in knowing what fraction of them you actually do you guys think are successful at doing so? And are you going to leave somebody at an LDL of 150? I know from our IVUS studies that they've already got tons of plaque in their coronaries. Most of them will have, if you were to put an IVUS probe down their coronaries, we know we know they're going to have plaques there. We know that half the population is going to die of cardiovascular disease. You calculate their ACC-AHA risk score, and they're going to be under 5%. You willing to leave them where they are?
Well, why not do not an intravascular ultrasound, but a CT angio? I think you like those tests. Why not just order one of those?
Well, I hate them. You know, I don't think
just prodding.
I don't think it. You're agile provocateur, Dr. Bott. I don't think making people glow in the dark from radiation in order to decide whether to use a $3 a month drug makes a lot of sense.
All right, how about CT angios? What do you think? Coronary calcium or
I don't
outright
order a lot
CT
of
angio?
CT angios. I don't even order a lot of coronary calcium scans. I do use them sometimes, but not frequently. But I would tell you this patient that you're talking about, Steve, I agree and I disagree. What I agree about
you're
is
so
the response to diet and lifestyle. What I disagree about is how we measure response. And we measure response numerically. Did the blood pressure go down? Did the hemoglobin A1C go down? Did the cholesterol go down? But what we have to think about with diet and lifestyle is it's like adding an aspirin. It's maybe like adding some other preventive cardiovascular agents that we're going to talk more about today. So I intervene with diet and lifestyle and say, in addition to this, we're also going to start you on a statin because the diet and the lifestyle isn't going to fix your cholesterol of 150 because a cholesterol of 150 is not something you do to yourself. It's something your parents did to you because it's inherently probably a SNP in one of the multiple genes that control the LDL receptor or its function. So I think it's a combination of both, and I agree you can't fix it with diet and lifestyle, but you should do it anyway.
I completely agree, and that's what I do.
All right.
Is I say, good, I say, look, change your lifestyle, do these things, and here is an entry dose, you know, and I start people at a low dose, 5 of Rasuva or 10 of Atorva, which generally is well tolerated. You don't see a lot of muscle complaints. And I know I'm going to get a 35–40% reduction in their LDL, and I'm going to sleep better at night, knowing that I have not left that patient. And you know, here's the problem is, I may not see that patient again. You don't know what their future holds. And 10 years from now, they may still have an LDL of 150 or 100, and nobody's done anything.
Well, the problem, so that's fine and good if you have those patients that are willing to go on a statin. The problem is I get referrals for patients that are vehemently opposed to starting a statin, either because they had a relative who had a side effect or they read in the internet that there were some issues. So they do not, under no circumstances, will try a statin. And that's, you know, that becomes an issue. But, you know, we will try to give them maybe Metamucil or some soluble fiber to take and then consider, will you take ezetimibe or will you do something? Or sometimes you have to have an approach with a patient where you might do a coronary calcium if it's a tiebreaker. Will you go on a statin if we can show that you have coronary calcium? And some will say yes, others will say no.